Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The guest on this podcast episode has no disclosures to declare.
Hello, everyone. This is Dr. Shannon Westin, your JCO social media editor, here with another episode of our Journal of Clinical Oncology After Hours podcast. So excited to bring you in-depth discussion on some of the amazing studies and manuscripts that have been published in the JCO. I am joined today by Dr. Virginia Sun, who's Associate Professor in the Division of Nursing Research and Education and the Department of Population Sciences Education at City of Hope. She has 17 years experience as an oncology nurse, 4 years experience as a nurse practitioner before becoming a full-time nurse scientist. And her research program is meant to develop and test interventions to improve patient and family-centered care and outcomes, specifically on cancer surgery and cancer survivorship populations. And what better person to have with us today as we're discussing the article, Patient-Reported Outcome-Based Symptom Management versus Usual Care After Lung Cancer Surgery, a multicenter randomized controlled trial by Dr. Dye and colleagues. So welcome, Dr. Sun. So excited to chat with you today.
Thank you so much for the opportunity to be here.
So let's get right into it. I think this article caught several of the editors' attention because it really is an exciting foray into how we might take care of patients after surgery. And as a surgeon myself, I was completely intrigued. So I can't wait to get your perspective. So let's start off first. The authors note that patients with lung cancer have a high symptom burden after surgery. As a non-lung cancer expert, can you walk those of us through a typical post-op course and some of the issues that might be experienced by these patients?
Sure. So I think symptoms is something that probably all of our patients who just underwent surgery experience, but for our patients with lung cancer, some of the common symptoms would include pain. I think pain is one of those universal symptoms that many of our patients experience after a procedure. But particularly for this population, they would also experience shortness of breath, of course, because anatomically there were certain parts of their lung that were removed as part of the procedure. Cough is something that they would experience regularly as well. And I think sleep disturbance is one of those general symptoms that all of our patients may experience. And also just emotionally, the anxiety perhaps and the stress may continue probably in the immediate post-op timeframe when they're just transition home. And then also the functional decline also happening along with the fatigue. Many of our patients, although we get them up and out of bed as soon as possible as a nurse, I know that's generally sort of our responsibility in the post-op recovery period. Certainly fatigue and the functional decline is something that our patients will experience in this population as well.
Certainly, many of those are universal across what we see in patients in the postoperative period. But I know personally, and I'm sure you could speak to this as well, we're busy post-op, right? I mean, especially, whether you're rounding in the hospital or you're seeing patients in post-op in the clinic, I don't know, how much we really get super deep dive into a lot of these symptoms. So I think that's what makes this work so important. So I'll just have you, if you could, briefly discuss this study design that was performed by Dr. Dye and Dr. Shi and their colleagues.
Sure. So the intervention is really patient-reported outcome-based symptom management. And this is done by way of alerts and completion of the MD Anderson symptom inventory, which is a very well-known symptom inventory tool, well validated within this population as well. And also when patients share that information after surgery and while they're recovering in the hospital, that will prompt an alert. So there were predetermined thresholds by way of the symptom score. So if a patient on the trial that reported a 4 to 10, which is generally a moderate to severe intensity for a symptom, and that will trigger an alert to the surgeon and the surgical team for management purposes. Now, in terms of this trial, the investigators chose several very relevant symptoms to focus on for this population to assess, and that would include pain, fatigue, cough, shortness of breath, and sleep disturbance. Although the MD Anderson symptom inventory does cover more of symptoms and beyond those as well. And in addition, I think, to the surgeon's response to the alerts, there were also other management, I think, that were triggered from the alert itself. So there may have been other services that were triggered as part of the intervention. But the first line of response to the alert were from the surgeons for this particular trial. So the patients, after they were discharged home, continued to provide, I believe, twice weekly symptom information by way of completing the MD Anderson symptom inventory. These are all done electronically. And then the alerts, I think, were continued. And this was done up to 4 weeks post discharge. And they also did include data that's collected in the pre-op setting, I think one baseline. And then after post-op, there were several data collection time points. In the hospitalization period, I believe it was a daily symptom report. And then after they return home in the first 4 weeks, it's, I think, twice a week.
I think it's perfect to have a way to automatically alert the surgeon and their team. Because again,
Yes.
if we just don't have time to engage on that level with the patients can you imagine every day your team having to call? I mean, that is just the amount of operationalizing that would take would just be bonkers. And so I love this because I'm already kind of thinking tick, tick, tick in my mind, like, okay, how would I incorporate this to the patients of mine that are in the post-op setting? So tell us, should I do that? What are the benefits of incorporating patient-reported outcomes into the post-op care? And then, of course, were there any negatives to the strategy?
Sure. I think we have quite a bit of evidence now by way of patient-reported outcomes guided management. This was done in many different settings, I think primarily starting in the chemotherapy setting, but now more and more in the surgery population as well. And so I think first and foremost, it's a great way to make care more patient-centered, right? Everything is driven by the patient's needs. And everyone may be presenting different symptoms at the same time, even though there are common symptoms that we may see from patients with lung cancer after surgery. But it makes it really personalized and relevant to each of the individual patients. Another way I think about it is sort of the proactive versus reactive approach of postoperative care. In most settings, perhaps, I don't want to say all, but certainly in most settings, our approach to postoperative management, while the patients are at home and in the community, I think are more largely reactive. So most of the time we may, we have information that we give to patients. If you are having any symptoms or you're meeting any of these criteria where you have a fever or anything like that, please call us. And many institutions may have a phone number that patients can contact during business hours or after hours. But this approach gives patient an opportunity and place to sort of contact us when they're experiencing challenges, but it relies on the patients, right? So it's still the patients who need to remember that, I need to call when I have these things. In most situations, unfortunately, it may be a little too late. We may get a phone call from patients or families when it's kind of at a crisis mode and we need to bring them in where they need to be readmitted. So I think the patient-reported outcomes approach, to me, is more of a proactive way. The patients share their information with us at certain time points during the perioperative setting or postoperative setting. And the healthcare team and the oncology team, the surgical team, somebody on that team is the one who is monitoring or getting the alerts from this team. And then we proactively contact the patients to perhaps assess and manage. So I think another way that I kind of tend to look at it is that the responsibility is really on the healthcare team to sort of act on the patient's information rather than sort of more of the reactive approach where we wait for patients to call us when they are having pain issues, when they're having sleep disturbance issues or shortness of breath issues. By that, it kind of makes also for a more patient-centered approach too, that patients have a way to communicate with us and they know that someone is on the other end that will be reacting.
Well, and I think, some of the symptoms that you're covering, like, I feel like patients will call for, oh gosh, I'm really short of breath, or, my pain is uncontrolled. Like, people feel really comfortable with that. But some of the other things like, well, I'm not sleeping that well, or, some of the other things that could be precursors to a worse issue, they, exactly to your point, they may not call early on, and then you get behind the 8 ball and you're in a really serious situation. So I like this. And I like that they know, okay, there's someone on the other end of this. I'm not just like shouting my issues out into the ether. Like, someone is going to hear this and respond. And then conversely, the care team is prepared. Like, they know, okay, these are coming in and these are the triggers. These are the thresholds at which we're going to mobilize what, okay, we're going to get pulmonology involved for this, or we're going to, bring the patient into clinic to have them look at a wound or whatever. I think, to me, this makes so much sense. Do you see any negative? How's the burden on the patient, I guess, is one obvious question.
From this trial, we see that in the investigators did assess and try to examine sort of the burden on both the patients and I believe the surgical team as well. And the patients were very favorable in their response in terms of the system, because it's another way for them to communicate with the care team, especially for our surgery patients who are, before surgery at home, right? There may be some visits, but they're mainly out in the community and in the home setting. And then, of course, when they're discharged after. So one of the things I think we should think about is, this is, of course, and this is a great study, but it's done in I would think, a different healthcare system. So this is a study out of China. And so is it replicable perhaps within the United States healthcare system, where there may be differences in terms of when we get patients into the OR versus sort of the care that's provided after? And who will be monitoring this information? It's great to see that the surgeons, and I think the data from this trial shows that on average, it took them 3 minutes to manage some of the symptom alerts, which is great. 3 minutes is actually really, really amazingly quick, right?
That's incredible.
I know, which is great. But, is it possible, for example, within a healthcare system in the United States, and of course, within the United States, different healthcare systems have different systems too. And so it's identifying who are the people that are going to be receiving this information. And then are there resources for them to be able to react in a timely fashion? And then communication processes in place with the surgeon and the surgical team if there is a need. Because I think that would be helpful in terms of these types of information, these types of trials being helpful for surgeons and surgical teams to make decisions about care. Should we be bringing the patient in a little bit earlier, for example, for the first post-op visit, or do we need to see them a little bit more often? The other thing I think that would be very important for us to think about is the digital health and the digital technology disparities. Technology is great, being able to capture symptoms in a remote fashion electronically and in a relatively quick fashion is great. But we also, I think, need to be mindful of the fact that, what is the comfort in terms of using these kind of programs and devices? And does everyone have access to this? During the pandemic, we've heard a lot about telehealth. We use telehealth quite often, and telehealth has great potential, but telehealth and digital health can also create disparities. And so I think we just need to be mindful of the population and, perhaps be mindful of the fact that not all patients and families will come with the knowledge in relation to using mobile applications or technology-based programs, and just have those support systems in place so that we can make things equitable, right? And that everyone will be able to access these kind of systems to communicate with their surgical team.
That's a great point. And I could see something around the fact of, for the patient population that maybe doesn't have the devices necessary, needing to kind of lend out devices to the patients and make sure that the nursing staff or medical assistants can counsel the patients and make sure walk them through the process. So yeah, I could see where that would be a place where making sure that it was generalizable to the population here and equitable will be essential. The other thing and this may be completely off base is, for us, and I think for you all as well, we use quite a bit of enhanced recovery. We have a pretty elaborate enhanced recovery program across really all of our surgical services. And I noticed that wasn't something that was mentioned in this particular article. I don't know if that's something that they were doing. Do you think that would have an impact in any way on these findings, or if there's a way to incorporate this into some type of enhanced recovery pathway?
I think definitely. Perhaps the more long-term, if there is a need to do more long-term remote monitoring when patients are out in the community, or more frequent timeframes in terms of follow-up. A lot of this work can also be thinking about what does the data mean and how can this data, not only drive sort of the symptom management piece, but is there a way for us to utilize this data perhaps at the very beginning, as part of a ERAS program, right? In terms of being able to identify those who may need a little bit more communication or monitoring after they're discharged home. So I don't see this as replacing the ERAS program. I see it as something that could potentially enhance and perhaps really be able to bring in that program and that approach where we are able to see what's happening to our patients when they're in the community, out at home while they're recovering. So I see it as an augmenting rather than a replacement, if you will.
Well, and I think that's really how enhanced recovery has been. I feel like when we first started, we had like some of the basics and then we added on, okay, let's reduce opioids and let's send less opiates home. And, and okay, we're going to inject the incision, so I feel like that's what's great about that pathway is you can keep kind of adding to it. And I guess that leads to my final question. I can't believe how quickly time has passed in this discussion. What fun. What do you think ultimately this study is going to mean for clinical practice? Like, do you think this is ready for prime time or kind of what are next steps for us here, in the States or our colleagues in Europe? Is this something that we can start doing?
Sure. Great question. So I think definitely there's pretty strong evidence now within, oncology care that remote monitoring, whether it's symptoms and other approaches, definitely has a benefit. Our patients appreciate the opportunity to communicate with their care team this way. And it's beneficial for the clinical team as well to understand what's happening to our patients out in the communities, and especially for surgery patients when they're recovering. In terms of whether it's ready for prime time, I think we definitely need to maybe replicate a trial like this within a United States or a European healthcare system and really be able to understand, who are the key stakeholders in this process, right? The patients, the surgeons, the surgical team, or nurses or other team members that are going to either be monitoring this data or benefit from the data that's being collected from patients and in terms of guiding the clinical care. I think it would be important to understand the processes a little bit better in terms of who's responding and then what happened during these encounters, for example. What are the things that we're hearing from patients so that within a system or within an institution, we can understand what are the resources needed to have a program like this take place, but also understand more from the patient and the surgical team perspective in terms of how this could benefit care. And then also, I think the other piece I think would be important for us to think about is beyond symptom monitoring, are there other perhaps information that would be worthwhile to remote monitor or collect from patients? For example, for surgical populations, perhaps functional recovery is something that is quite important. And so is there some other data that we can incorporate beyond sort of the subjective reports, which are very important, but is there a way perhaps to think about subjective and objective measures combined together and really be able to understand what it means in terms of the data that we're collecting? And then also what types of symptoms data, for example, and other kinds of data that we absolutely should collect versus everything under the sun, right? That is going to be most helpful in terms of informing care for our patients. This is because, by way of thinking about burden, we can collect data. I think the technology is there to collect data as much as possible, but how we use it and what does that data mean, we still need to understand a lot of that work. And so I think bottom line, no doubt, this is something that's beneficial from the patient's perspective and the cancer care delivery, surgical team perspective as well. But understanding a little bit more about the stakeholders' perspectives and the details of the care, I think will make it much more efficient and more successful, perhaps, in terms of implementing into standard of care.
Great. Wow. Well, thank you so much. This was an awesome discussion. And I know our listeners will be intrigued and hopefully are planning some trials of their own to explore the use of these patient-reported outcomes. So listeners, thank you so much again for tuning in to JCO After Hours, and we will see you again next time.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.